Why is that the case? We were making progress, apparently, and while no one can say for sure, it may not be a coincidence that 2004 was the year in which the black box warning was placed on antidepressant medications, warning parents and prescribers of the potential dangers and increase in suicidal ideation, not necessarily suicidality, that can come from prescribing antidepressants to teenagers and young adults. Another interesting fact is that females attempt suicide 3 to 4 times as often as males. Perhaps that's because females are more likely, more subject to depression. Perhaps it's because they're under greater stress in our society. There are a number of possible explanations for that. But it's also interesting to note that males, as you saw in the graph that I showed you, complete suicide about 4 times as often as females and up to 6 times as often in the 20 to 24 year age group. Why is that? Males tend to select more lethal means, generally firearms, as a way of attempting suicide, whereas females tend more often to choose overdoses, which many times do not result in their death. Nationally, more than 80 out of every 1,000 teens will attempt suicide in a given year, according to the Center for Disease Control and Prevention. What's the implication of that? Let me put it in these terms. If 80 out of every 1,000 teens will attempt suicide in a given year, that means that in a high school class of 30 students, during the school year, statistically, 2 of those students will attempt suicide. And many times, no one in the school realizes that they've done it. Those children need help. And yet, there's an underestimation of the scope of the problem, and very often little or nothing is done about it once it happens. That's a chilling fact about the number of students who attempt suicide in a 30-person class. There are many myths about suicide and suicidality. I'd like to discuss some of those and dispel the myths. If you ask somebody about his or her suicidal intentions, will you encourage the idea of suicide? I talked about that briefly earlier. The fact is that talking or asking about suicide will not cause a person to kill him or herself, nor will it give them the idea if they haven't had it already. Suicide can happen without warning, and people who talk about killing themselves rarely actually kill themselves. That too is a myth. Most people who die by suicide have given some verbal clues or warning of their intention. That's usually to a friend or sometimes to a medical professional. And why is it that the friend may not do anything about it? Usually because the person who has told them has asked them not to say anything, and they put themselves in a bind that way. Or it may be because they don't want to hear it or don't know what to do. And how about medical professionals who've been told that the person is feeling suicidal? Once again, many medical professionals don't know what to do. It's only recently that suicide prevention training has become a routine part of the medical curriculum in our medical schools. But that's not the case in every medical school, and lots of education is needed. A person who's lost a close family member to suicide has a lower risk for suicide. That's certainly not true, even though one might anticipate that a person who's lost a loved one by suicide would understand the pain and never want to foist that pain on someone else. But the fact is that mental illness runs in families, and suicidality seems to run in families. Research has shown that a family history of suicide is a huge risk factor. And survivors of suicide, meaning that someone close to them has completed suicide, are on the average 6 times more likely to die by suicide themselves than people who've not been touched by suicide. However, there are fewer and fewer people now who have not been touched by suicide. We'll talk about that more in a few moments. I understand the feelings that some people have when they've lost a loved one by suicide. 2 of my brothers completed suicide, and I realize the pain that that causes family members, the difficulty adjusting and coping. And even though I am not suicidal and have no suicidal ideation, still, statistically, I'm at much greater risk. Is it true that all suicidal people are deeply depressed? And that, fairly obviously, to those of us who are mental health professionals, is not true. Depression is closely associated with suicidal feelings, but not all people who are depressed attempt suicide, and not all people who complete suicide or who attempt it are obviously depressed. Sometimes depression takes different forms at different developmental and different age levels. In addition, there are a number of people with mental disorders, not necessarily characterized by depression, who are at greatly increased risk for suicide themselves. People with various anxiety disorders, including, as we've seen from the increased suicide risk in the military, post-traumatic stress disorder, are at greater risk for suicide. People with schizophrenia, particularly those who have negative hallucinations, are at risk for suicide. People with bipolar disorder are at risk, and that's not confined to the time when they are in the depressive phase of that illness. People with borderline personality disorder, who may not have concomitant depression at any given time, are still a higher suicidal risk, and so forth. I told you that we'd talk a little bit more about the effects of suicide on others. Each suicide intimately affects, on the average, 6 other people, changing their lives forever. And I, as I mentioned to you, know the personal pain and how that does change a person's life forever. Sometimes, well, often, maybe even always at first, in negative ways. Sometimes, however, it can inspire people to do positive things like engage in suicide prevention efforts. Therefore, based on a suicide figure in the United States of 32 to 33,000 annually, that means that about 200,000 people annually have their lives changed forever in the U.S. by completed suicide. A new person is affected by suicide in this country about every 3 minutes. And some of the most painful, some of the most difficult suicides to contemplate and with which to cope are teen suicides and the suicides of children. 9 out of 10 teen suicides take place in the home just before parents return from work. Think about the implications of that for a moment. Is there a message? Is there something that we should learn from that? What's the implication of the fact that 9 out of 10 of those teen suicides occur just before parents return home from work? Are the teens sending a message to their parents? Are they trying to be saved? Or does it indicate that we have lots of latchkey kids who need closer supervision? Perhaps all of those things. About half of teen suicide victims had been in trouble with the law or had been in trouble with their school prior to completing suicide. So we need to keep that in mind as a very important risk factor. Getting into trouble with the authorities, whether that be the police or the authorities at school, is a big warning sign. Almost half of teen suicide victims were known to abuse substances of some sort, alcohol or drugs. And so another very important warning signal for us. And a very good reason to do drug prevention activities in schools and in the community. According to the Surgeon General, more than 80% of teens who killed themselves had a diagnosable mental disorder at the time of their death. It's important for us to understand the very real possibility that that's an underestimate. But the fact is that whether it's 80%, whether it's 90%, whether it's some other figure that is close to that, there's a tremendous problem with undiagnosed mental disorders, especially among our youth. The Surgeon General's report on mental health among youth indicated that approximately 20% of our young people at any given time has a diagnosable mental disorder, and from 7 to 9% have a severe emotional disturbance, which is sufficient to cause significant problems in their lives and possibly contribute to suicidality. You can't tell, however, unless you assess. As Maxine says, everyone seems normal until you get to know them. So it's really important for us to have some sort of plan, some sort of screening process to help determine who's at risk and who might need intervention because of that risk for suicidality. What are some of the risk factors that we need to keep in mind and that we can use in the screening process? Well, one of those is previous suicide attempts. It's almost as if past suicide attempts constitute rehearsals for future suicide attempts, because with each attempt, the probability of future attempts goes up and the probability of eventual completion of suicide goes up almost geometrically. So it's really important to ask about prior attempts. A history of mental disorders is critical as well. As I mentioned, most people who attempt and who complete suicide have a diagnosable mental disorder at the time. And if they have a history of mental disorders, even if they don't seem to be experiencing that disorder at a given time, they still are at greater risk, particularly with some of the disorders that I mentioned before. A history of alcohol or substance abuse, and that's true at all age levels. Perhaps you know that the profile of the individual who is most likely to attempt suicide and most likely to complete it is not the profile of an adolescent or a young adult. It's the profile of an elderly man who has just lost someone important in his life, an elderly man who has limited support systems, an elderly man who abuses alcohol or drugs, usually alcohol, an elderly man who has ready access to a firearm, usually one in the home, and an elderly man who has consulted his physician recently about a problem that might suggest somatization of depression. If you know an elderly person who meets those characteristics or who has those characteristics, clearly they're at risk, and clearly some intervention should be undertaken. Another risk factor is a family history of suicide, as we mentioned before. And that family history can be because of a history of mental disorders, or it can simply be because there is that possibility that's passed on perhaps in some behavioral ways as well. A pro-suicide culture or religious beliefs, those things can increase the risk of suicide. Cult beliefs in suicidality, sort of like what happened at Jonestown in Guyana. Anything that brings peer pressure on an individual to complete suicide or on a group to complete suicide can have the effect of raising the risk. Then illness, particularly if the illness is chronic and especially if it involves unremitting pain. Back pain is very common in our culture, and people who have relentless back pain are very often at risk for suicide, especially as the pain wears on them. They're also at risk for substance abuse, the abuse of pain medications, and that increases the risk dramatically. Then those with barriers to accessing mental health treatment. Personally, I was delighted when the Congress passed the mental health parity bill. Unfortunately, it was just an add-on to the recovery, the TARP legislation, but it passed. And the unfortunate thing about that is that there are many loopholes, so that access to mental health treatment and barriers to mental health treatment, barriers still exist. The access to treatment is still quite problematic, and those barriers constitute risk factors. Significant others, as I mentioned before, who've completed suicide raise the risk dramatically.